I'm Robert Hawkins. I'm an adult cardiac surgeon here at the University of Michigan, and I'm part of our complex coronary team. And so today we will be discussing a patient who is presenting with an acute coronary syndrome with three vessel disease and diabetes. For these patients, the most common scenario for residents is going to be some type of acute coronary syndrome, whether that's unstable angina or an NSTEMI. That algorithm can be pretty regimented. What we try to do here is have for all of these patients, both interventional cardiology and cardiac surgery evaluate patients. From the interventional cardiology side, we want them to weigh in on the intricacies of PCI options, whether it's feasible, what they think the durability of stenting would be, and then also we want a syntax score from them. So that way we get some objective data about the complexity of the coronary disease. And then from the cardiac surgery side, we have a series of preoperative testing that we want to do, and that's going to be based on indications. And so most, though not all, surgeons here get a CT scan of some kind. So I would recommend a non-contrast CT chest. You can get an immense amount of data from that. But mostly it is going to tell you whether the operation is going to really be feasible, whether there's aortic calcifications, coronary calcifications, if there's a spot to actually sew to where you can clamp. You can even see the IMAs, even on a non-contrast CT scan. So you can get pretty much all of the operative planning data from that in conjunction with your cath. Then in terms of risk stratification, for patients who are smokers or have other high-risk pulmonary features, getting PFTs can be helpful. And then carotid duplex is indicated, so there are some guidelines related to who should or should not get a carotid duplex. In reality, at most major centers, pretty much everyone gets a carotid duplex, but that's not always necessary. Some of the common main indications are going to be proximal left main disease, peripheral arterial disease, known carotid bruit, for example, smokers. Most of the time, the risk factors for coronary disease overlap, and so pretty much everyone is going to end up getting a carotid duplex. And then you need an echo. Sometimes patients come in with a surprising number of patients will either have suboptimal echoes or stress echoes. Again, I would caution using stress echoes. You really got to look at the images yourself to make sure that they get complete images. You really need a complete echo. For example, I've had a case where there was missed severe aortic insufficiency on a stress echo that you find intraoperatively on a TEE, for example. And the goal here is to, one, identify risk factors and use all of that data to enter it into our STS risk score, but also prevent any surprises. And so once you get all of your data from the surgical side, what we want to do is what is the feasibility of surgery and what is the STS risk of mortality. We can then enter that data and get estimates as to whether PCI or CABG is going to be superior. And essentially the way I describe it with patients is surgery has an upfront risk with long-term durability and benefits. And in certain acute coronary syndromes or other coronary disease patterns, there's a survival benefit over stents, which is lower upfront risk. But long-term, you can develop in-stent restenosis or other issues with the stents that our interventional colleagues can help us define for those patients. And then we have a committee conversation between cardiology and surgery, and we make a recommendation to patients. Surgery is clearly better, PCI is clearly better, or both are options, and we talk to the patient about what they would prefer. In sick patients that are very high risk, those life priorities can be very different from young and healthy patients. So understanding the patient's goals is going to help you make the best recommendation for them. Then once you have a decision about surgery, so in this case, there's proximal LAD disease with diabetes and three vessel disease. So we know at 5 and 10 years, this patient is likely going to have a survival benefit with CABG. So if they're low risk, that would be the recommendation from our group. Then the question becomes how best to complete that. So the technical questions related to the surgery would be on pump versus off pump and how to do the revascularization. The main goal is going to be complete revascularization. So we know patients do best when you revascularize all ischemic areas. But there are 4 different conduit options that we can choose from. The gastric plug is very rarely used, but it is an option. And then the more standard option, which is the Lima and vein. If the other option to consider would be multi-arterial with either radial or REMA. And so those conversations can be more in-depth and probably suited to another podcast. But the main areas of concern for radials would be whether or not you would need the radial in the future, such as with chronic kidney disease, or if they have incomplete arch and incomplete circulation, that would put some of the hand at risk for ischemia. So adequate testing would be a requirement for that. And then the data on BEMA, for example, there's a recent study out from the STS database suggesting that the risk of sternal wound infection is about double for patients. And in low volume centers, there may be an increased perioperative risk of using BEMA. And so to do that, we would just want the surgeon to be comfortable with that approach. And so if a surgeon is comfortable with a BEMA, there are a variety of different ways to do that as well. So it also has to fit the anatomy, where you're going to sew these grafts to, how you're going to route them, whether that's through the transverse sinus, whether you're going to use a REMA across midline to the LAD, and then use your LEMA onto the lateral wall. All of these considerations can be taken in to try to come up with the best operative plan. Again, having those conversations with the patient as to what their goals and priorities are. the data on benefits of multi-arterial grafting are not entirely clear. And so it appears that there's a survival benefit, but that survival benefit may take up to a decade to appear. So, for example, a low ejection fraction patient who has a very high 5-year mortality is probably not going to benefit from a complex multi-arterial grafting operation, as opposed to a very quick NEMA with vein to get them off the table and get them home safely. So those kinds of conversations I have with the patient about their priorities, my priorities, and what we can safely do, and what we can try to do to prolong their long-term mortality.